Actually, it really amazingly parallels what Jared and Leonor have already said, and so I'm going to try to focus a little bit more on the mental health, what we might more relevant for mental health. Next slide. Nothing to disclose. So as John mentioned earlier when we started, VA actually went live with Open Notes in January 2013. So we now have over 6 years of experience with Open Notes. And in contrast to most systems that I'm aware of, there's really no provision to block any notes, including mental health notes. And over the years, people have raised concerns about mental health care and Open Notes, concerns about potential patient confusion or exacerbation of symptoms, and also issues around privacy and confidentiality. So what we did is we had a VA-funded study that had really 2 goals. One was to understand veteran and clinician perspectives and experiences around VA Open Notes as relates to mental health care, and then also to develop really 2 training programs, one for clinicians, one for veterans, that would minimize unintended consequences of Open Notes use in mental health care, but also hopefully optimize communication and collaboration. So what we did is we started out the project by doing a lot of qualitative interviews with veterans and clinicians, actually about 28 each, really trying to understand people's experiences with Open Notes and actually get their advice and really develop some content that would go into the training program. And so one of the key findings from veterans is that reading clinical notes online can either strengthen or strain trust in clinicians. And it was really all about trust. And so it turns out that if you have a good relationship with your provider, if the patient and provider have a good relationship or a long-standing relationship, what you write in a note is probably not going to make that much difference. On the other hand, if the patient's more ambivalent about care or about you as a provider, then what you write in the note can actually be pretty critical. And so I listed just a few quotes here to exemplify a few of those findings. The first one, I'd like my clinician to take it seriously too, not just spit something out on paper and not proofread it. Did the clinician actually listen to me? It seems like a very different person written about in the notes at times. And now a more positive one. I like the way my clinician puts them in because he's very blunt and honest. He pretty much says exactly what I've said. And what I really like about it is that he also puts in there what we talked about and what I said I would do. So as I mentioned, we developed a training program. This is the one for clinicians. You are welcome to try that link at a later time to get access to it, but I can't guarantee that link will remain active. And I ask that for the next week, you not share that link with others because I need to use it at another talk in a week. So anyway, next slide. We developed the CLEAR strategy. So this is in the clinician training program. It's really just an acronym. And as you'll see, it really overlaps greatly with what Jared presented. Next slide. And I'll walk us through some of the things, again, that I think might be a little different or new. So connect the visit to the notes. Or really connect the notes to the visit. As Jared said, discuss what you write and write what you discuss. Be thoughtful about language. And so this has come up obviously in the other presentations, but I do want to emphasize that veterans really thought, and clinicians, that you should use language that mirrors how you speak with patients. You really shouldn't be writing in a way that you wouldn't have a conversation with the patient in the room. And in mental health care, that's actually quite possible. A lot of what we think and do and write about is not particularly technical. And the other thing is there's some terms in mental health like somatizer or schizophrenic that are very, very labeling. And so you can phrase things a little bit differently. You can say a person with schizophrenia, for example, rather than labeling someone as a schizophrenic. One of the things that I think is that you can really do in mental health treatment is to encourage patient strengths and progress. And so you can really balance problems, deficits with patient strengths and resources. and really document goals and progress towards recovery. So kind of a before example, it might be, I'm not sure the veteran will be capable of going back to work in light of her level of anxiety. Well, that might be rephrased to something like, Ms. Thompson continues to discuss her goal of returning to school next year. She reported feeling nervous about applying. We discussed her qualifications, including the classes she's already completed and her strong math skills. So I think kind of a little spoonful of sugar can sometimes help. And I think this is also quite relevant when you get into more difficult types of conversations you've had with patients, as well as challenging notes to write. And A in the CLEAR acronym is audience. Consider who may read the note. It can be pretty helpful to talk to the patient about the purpose of notes and remind them that there are multiple audiences. There may be billers, there may be legal issues. And I think what I want to convey here is really to be thinking about what details are critical when documenting personal or sensitive information. So I give an example here about a patient talking about an affair that his neighbor is having. Is that really necessary, the details of that, to be in the note? For one thing, you don't know who is reading the note. It may not be the patient, it may be the patient's spouse. On the other hand, you do want to include enough detail so that enough clinician can effectively assume care. And this general principle applies to trauma in general. You may not need to get into nitty-gritty details some of the time, but you probably need to provide enough information that a clinician can understand the seriousness of the event and the general experience the patient has. And finally, R is to show respect and to be professional. I already mentioned some of the terms used. We found that veterans, and I assume other patients, like it when their names are used. So instead of saying patient says this or veteran says this, you can say Mr. Johnson. And then also being attentive to preferred names or pronouns is important. I want to go back and also emphasize that the cut and paste, patients pick up on that really quickly. And so I think this is really getting back to the connecting the visit to the note. You can just put one or two little things in your note that were particular to what was discussed in that session. And that's very, very important to patients. And then challenging situations, again, you want to avoid having anything show up in the note that wasn't discussed in the session. Sometimes with a differential diagnosis, say, for example, schizophrenia, you can think in terms of a differential diagnosis. Share with the patient that you're not completely sure, share your thinking process. This can be quite helpful. And then, as I mentioned, include some hope for recovery as well when you're writing about what otherwise might be bad news. I think also when you're documenting sensitive information, it may be helpful to discuss with the patient what you're going to document. And sometimes the patient, you may be able to give them some input into what degree of detail you put into the note. I think Jared mentioned writing the note with the patient, and we definitely do that when sometimes there's more contentious interactions with patients. It takes a lot more time, it's more complicated, but really kind of writing the note together and talking it through is a strategy that can be helpful in particularly challenging situations. I would also strongly encourage you to reach out to colleagues or a supervisor to get advice on completing notes. And even though people often ask me for advice, I will also ask others for advice. And finally, what can really help orient? I think discussing the availability of open notes through Blue Button, talking about progress notes, talking about how patients can use their notes, and providing opportunities for patients to discuss notes or ask questions. We know from our research that patients are very unlikely to bring up open notes with their clinicians if the clinician hasn't brought it up first. And in our study, we also found that orienting patients to open notes was associated with a 4 times increase in the odds of them actually reading their mental health notes in general. So if we want patients with mental health conditions to use open notes, we really need to talk to them about it. And that's all I have. I have one more slide with references. I'm also happy if somebody emails me to send you a copy of a pretty detailed outline of our training program.